So we start today's proceedings with a platform presentation session. To chair this session, I would like to invite on stage Dr. Yojana Gokhale and Dr. Pradipta Shekhar Patro. Dr. Yojana is the Professor of Medicine and in charge of Rheumatology Services at Lokmanya Tilak Medical College and Sion Hospital, Mumbai. And Dr. Pradipta Shekhar Patro is the Professor in the Department of Clinical Immunology and Rheumatology, IMS and Some Hospital and Medical Sciences, Bhubaneswar. So there will be three paper presentations in this session. I would now like to hand over the mic to the chairperson to start the proceedings of this session. Thank you.
So may I call upon Dr. Sri Netra. She's going to speak on longitudinal effect of cyclophosphamide-based treatment on type 1 interferon gene signature in proliferative lupus nephritis.
Very good morning, everyone. I am Sri Netra and I'll be presenting about longitudinal effect of cyclophosphamide-based treatment on type 1 interferon gene signature in proliferative lupus nephritis. So, to begin with, lupus is an autoinflammatory condition characterized by sustained autoantibody production, and lupus nephritis is a serious kidney manifestation that is currently managed with steroid, cyclophosphamide or MMF. As we know, amongst the different pathogenic triggers that mediate lupus nephritis, the most important cytokine is the type 1 interferon pathway, and that is induced by the activation of several TLRs, RLRs and MDA5. So there are very limited studies that understand the effect of cyclophosphamide on type 1 interferon signatures in proliferative lupus nephritis, and with this rationale we wanted to assess the longitudinal effect of both high as well as low dose cyclophosphamide treatment on type 1 interferon signature in proliferative lupus nephritis, and we also wanted to assess its role in predicting treatment response. So we recruited 54 lupus patients, treatment naive lupus patients who fulfilled SLIC criteria, who had greater than 500 mg proteinuria with or without active casts, and patients above 18 years of age. We excluded patients with pre-existing renal failure, diabetes, or those who had a history of toxicity to immunosuppressive drugs, those with an ongoing episode of acute or chronic infection, in pregnant women. We also recruited 54 age and gender matched healthy controls without any family history of autoimmunity. So these patients, 27 each, were treated with either high dose, where they were given modified NIH protocol, and low dose, where they were given modified ELNT protocol. They were followed up for 6 months. Response at 6 months was assessed using EULAR-EDTA criteria, and they were stratified into 2 groups at the end of 6 months. Clinical responders that included both complete as well as partial responders and non-responders. So briefly, we collected 5 ml of blood from both the groups of patients at baseline, 3 month and 6 month. From the blood, we isolated PBMCs, RNA was extracted, and gene expression, interferon gene expression of the following genes was studied using qPCR. So initially, we stratified the patients as high and low dose groups, and we found all the clinical characteristics to be comparable between both the groups. Their histopathological features, including activity chronicity score, was also comparable between both the groups. Now, when we compared the interferon gene score, which we calculated using the log fold change normalized to healthy controls, we found that at baseline, there was an increase in the interferon gene score, but interestingly, at 3 months, there was a drop, and 6 months it increased back, but that level was again not as much as the baseline. So we found that the drop from baseline to 3 months was significant in both the high dose as well as the low dose group, and the increase from 3 to 6 months was seen only in the low dose group. We then calculated something called the delta IGS by subtracting the baseline score from that of the 3 month score, and we found that this delta IGS was also comparable between both the groups. We then stratified the patients as responders and non-responders, and we found that male sex, high serum creatinine, baseline serum creatinine, then endocapillary proliferation and interstitial inflammation to be significant between both the groups. Coming to their IGS scores, again this followed a similar pattern similar to that of the high and the low dose groups. So at baseline there was an increase, at 3 months there was a drop, and at 6 months there was an increase. So the drop from baseline to 3 months was significant amongst both the responder group as well as the non-responder group, but the increase from 3 to 6 months was seen only in the responder group. So when we calculated the delta IGS, or the fold change between baseline and 3 months, we found that to be significantly greater in the response compared to that of the non-response. So this was, delta IGS was significant between both the groups. So we performed a univariate logistic regression to identify independent predictors of non-response. We found delta IGS, then endocapillary proliferation, high baseline serum creatinine and interstitial inflammation to be significant ones. Now we found an association between high baseline serum creatinine and interstitial inflammation. That's why we included only interstitial inflammation for further analysis, because this was found to be a much stronger predictor of non-response than the other. So we then performed an ROC analysis, and on the ROC analysis, we wanted to predict, we wanted to assess the predictability of delta IGS to predict non-response, and then we found that in the presence of both endocapillary proliferation and interstitial inflammation, delta IGS had an AUC of 0.833, and with the cutoff of minus 0.81 and a sensitivity of 83.3% and a specificity of 71.4%, it was able to predict non-response. So our results conclude that both high dose as well as low dose cyclophosphamide regimens were capable of reducing interferon gene signature in proliferative lupus nephritis patients, and in the presence of endocapillary proliferation and interstitial inflammation at 0.81 folds by the end of 3 months, at a decrease of 0.81 folds compared to baseline. This delta IGS was capable of predicting non-response to cyclophosphamide based induction regimen with a sensitivity of 83.3% and a specificity of 71.4%. Thank you.
Any questions from the judges?
Yes, ma'am. Yes, ma'am.
Mike. Dr. Rohini.
So 3 months is a little later in the day to predict response. I mean, it could be better if it was earlier.
Okay.
So is that also could be included as part of your study? Because if you want to know whether this, of course, your sensitivity specificity is not very high, so there can be, you know, it may not be an absolute indicator, but if you could think of doing it earlier, it might be more helpful, is what I felt. But it's a good study.
Actually, this is a part of a bigger study, and we followed up these patients for 2 years. So I have included only a part. So it is serial sampling of these patients at baseline, 3 months, 6 months, and at the time of flare within 2 years. So we collected renal biopsies as well, and we are profiling their transcriptome at these particular stages. So that's why we had to now the point of collecting it at 3 months was to, because response is assessed at 6 months, if we have an intermittent time point to be able to know if a patient is responding or not responding towards this treatment, it will be better to devise the treatment accordingly, manage these patients accordingly. So that was the idea of collecting it at 3 months, but we will definitely take into consideration, ma'am.
Hello, your presentation was very rapid, so I didn't grasp everything you were saying. Can you just define to me how you defined response and non-response? Can you go over that? Okay.
So they were defined based on Euler EDTA criteria, sir. So any patient who had lesser than 500 mg of proteinuria were taken as complete responders. Along with less than 10% serum creatinine were taken as complete responders. Now patients who had greater than 500 mg of proteinuria, but it was lesser than 50% of their baseline proteinuria, those patients were taken as partial responders. So we included both complete and partial responders as clinical responders. So those patients who did not show any improvement in their proteinuria compared to that of baseline, then they were taken as non-responders.
Thank you, Dr. Srinithya.
Sorry, can I ask one more question? What other medication were these patients on, and did you give consideration to that in your analysis?
Yes, sir. We also assessed the cumulative steroid dose. We wanted to see if the changes were dose dependent, but they were independent of their doses. So we did take the medication because we recruited only treatment naive patients, and definitely the treatment will have an implication. So what we considered was the cumulative steroid dose, and we found that these changes were independent of that.
Thank you.
Thank you.
Thank you. Now I call upon our next presenter, Dr. Prakashini, MD. She's going to speak on transcriptomics of treatment naive MISC as compared to healthy controls, Kawasaki disease and systemic GI.
Good morning, everybody. I am Dr. Prakashini from Kalinga Institute of Medical Sciences, Bhubaneswar. So today I'll be presenting our research on transcriptomics in treatment naive multisystem inflammatory syndrome in children compared to healthy controls, Kawasaki disease and systemic GIA. These are my disclosures. What is MISC? It's a hyperinflammatory syndrome that usually occurs 4 to 6 weeks after a SARS-CoV-2 infection with a mortality rate of around 9%. The child presents to us with high-grade fever with or without heart failure, and it is clinically similar to Kawasaki disease and systemic GIA. However, the cytokine storm of MISC is different from that of COVID-19. I'll just rush through the criteria due to the lack of time. So the clinical study that's been done initially, it was a 28 patient cohort. All of them had fever and 50% of them have GI and shock. The studies that have been done till now on this study is that they saw the inflammatory profiling assays in Cell. This was published in Cell in 2020, where they saw 9 patients. They found that serology of MISC resembles COVID-19 convalescence, and the cytokine and the autoantibody profiles were different. In the same issue, they also saw that the T-cell profiles were different between MISC and Kawasaki disease. So what do we know about it till now? We know the cytokine profile, the T-cell profile, and the autoantibody profile. But we don't know the genes that are involved in the pathogenesis. So hence, we did transcriptomics to do that. So this is a research from our center where we published a 21 patient cohort of MISC, and they were followed up for 12 to 16 weeks, and at a median 15-week follow-up, there were no deaths. And we took 6 treatment naive patients from this cohort for a current study. We analyzed the gene expression patterns of MISC and compared with that of healthy controls, Kawasaki disease and systemic GIA. So 6 treatment naive patients of MISC were taken, whole blood transcriptomics were done, and RNA sequencing was done on Illumina platform. We looked at differentially expressed genes and the pathways involved. The statistical analysis was done on DE-seq2 library from R, and the gene set enrichment analysis was done on metascape.org, and p-value was corrected by false discovery rate to less than 0.05. So coming to the results, we saw a median age of 12 years with an interquartile range of 7 to 13 years, and 4 patients were female and 2 were male, and the controls were age and sex similar. This is a principal component analysis which shows that the genes for MISC clustered differently as compared to Kawasaki disease. These are the genes for MISC that clustered distinctly. And here we can see the overlapping and differentially expressed genes in healthy controls, Kawasaki and systemic GIA. And you can see that in Kawasaki, though it is considered phenotypically similar to MISC, there were a lot of genes that were differentially expressed. Then we saw the differential expression of genes. This is a volcano plot that compared MISC versus healthy controls. The genes which are present on the right and the top are the most upregulated and the most significant. So MYL9, that is the myosin light chain 9, integrin alpha 2B, DMTN were most upregulated compared to the healthy controls. And comparing the same with Kawasaki disease, we saw that platelet factor 4, ITGA2B and TMCC2 were upregulated. These all have a role in inflammation. And compared to systemic GIA also, we saw a common gene of ITGA2B, TMCC2 and DMTN. Then we did a gene set enrichment analysis. And compared to the healthy controls in MISC, we predominantly saw that the phagocytic pathway, the humoral immune response, complement activation were more upregulated. And compared to Kawasaki disease and systemic GIA, innate immune pathways more upregulated. So the data on transcriptomics has been scarce, and we found few novel genes of interest, and the upregulated pathways were the phagocytic and complement pathways, and interleukin 10 pathway was downregulated. So the strength of our study was that we identified novel genes, and there is very limited data on transcriptomics. And the weakness was it's a small sample size. So to conclude, whole blood transcriptomics has identified unique gene expressions, and there is scope for therapeutic implications by targeting specific pathways of genes that are upregulated. MISC is scientifically puzzling, but it is definitely therapeutically manageable. Thank you.
Questions from the judges?
So you implied there were therapeutic implications. Can you elaborate?
Now that we've identified specific gene sets that have been upregulated, we can probably try animal models where you can upregulate these genes and find a specific target for those genes and see if it helps in the treatment pathways.
So were all these common for all the 6, or you had different transcriptomic results in
the gene sets that were upregulated were different, ma'am, compared to
amongst the 6 patients.
I didn't get your question.
No, the genes that were upregulated, were they common to all the 6 patients?
Yes. The data that we presented is of the 6 patients, and it was compared with the 3 similar diseases.
Was it similar in all the 6 patients?
Yes. We've showed only the maximum upregulated genes.
Because the number is small, there may be variation if you had a larger number of patients.
Yes, the previous studies that have been published till now similar to this also have had like 9 or 13 sample size in cell. So that is a limitation, ma'am. We had a small sample size.
Because there are so many genes, and you have 6 patients, so you might find a different set of genes in a larger set of patients.
Yes.
Okay. Thank you, Dr. Prakash.
Thank you, sir.
So, today's third oral presentation, may I invite Dr. Avnish from CMC Vellore.
Good morning, everyone. I'm Avnish. I'm from CMC. I'll be presenting on the topic of utility of circulating immune complexes, cytokines, and monocyte subset analysis in SLE. I have no disclosures. SLE is a heterogeneous disease with both involvement of innate and adaptive arm, and we have few less than perfect markers like complements and anti-dsDNA. So there is an unmet need for disease activity markers. Monocytes are part of innate immune system, which are involved in cytokines release, as well as they can get converted into dendritic cells and also help in activation of B cells and T cells. This is a self-amplification loop between the innate and adaptive immunity. Both parts have their roles. Already there are 3 subsets of monocytes which have been already established on the basis of CD14 and CD16 expression. Also surface markers other than this, like chemokine receptors, as well as HLA-DR, CD163 have been found to be differentially expressed between these 3 type of subsets. Their cytokines are also different. So the objective is to immunophenotype the monocyte subsets in SLE and their relation to disease activity, to analyze the inflammatory and anti-inflammatory cytokine levels in SLE patients and according to their activity, and to quantitate the circulating immune complexes in serum of SLE patients with their correlation to disease activity. So we based our sample size based on another study on between classical and non-classical subset of monocytes, which was analyzed previously, and with a precision of 5%, we got sample size of 40. So ours was a prospective observational study. We included SLE patients, both new and old, patients were those who had flare, which was defined by the SLEDAI 2K score of 4 and above, and the controls were those who had no flare with the SLEDAI score lower. Monocytes were sorted using FACS as classical, intermediate, and non-classical on the basis of CD14 and 16 expression. And monocyte activation markers like HLA-DR 86 and 163 were also done, which are also differentially expressed and more in intermediate subset. And ELISA was done for circulating immune complexes using C1q as the catch. TNF alpha, IL-6 and TGF beta were looked at in cytokines. Exclusion was steroid dose 10 and above, and also pregnancy and active infection. Methodology, phenotyping of monocytes in all SLE patients was performed on stored PBMC, and markers, cocktail of antibodies was used for looking at their surface markers, and we then did flow cytometry and analyzed it using FlowJo. So these were the patient characteristics. The newer active patients were younger. They were earlier in diagnosis, most of them, and they had, as expected, higher SLEDAI. Both of steroid dose was, however, matched. FACS results. So we found that the monocytes were reduced in active disease, which was significant statistically, while the classical, intermediate, and non-classical subset, although there was a trend towards increase in intermediate subset in the active disease, it did not reach statistical significance. The other way of looking at fluorescence data is, flow cytometry data is looking at the mean fluorescence intensity, and that way, in that we found that CD11C, which is a marker of monocytes, the MFI was reduced in active disease, and also CD163X MFI, which is a marker of intermediate subset, was elevated in active disease. There was, however, otherwise there was no difference in white cell count, live cells in the between active and inactive disease. There was a trend towards significance of increase of intermediate subset, however, it was not statistically significant. This is the scatter plots for monocytes in healthy, controlled, inactive and active disease. In the active disease, if you can see, the intermediate subset is significantly looking higher, and this was also the case when we did the statistics, but it did not reach statistical significance. And monocytes, SLEDAI 2K actually correlated with negatively with the monocyte numbers, and CD11C MFI, and positive correlation with intermediate subset of monocytes, which were, and also CD14 163 positive monocytes, which is another way of looking at intermediate subset. ELISA values, we found that there is significant elevation of CIC, circulating immune complexes, and anti-dsDNA in the active disease, and both were statistically significant, and also TNF alpha was statistically elevated in patients with active disease. However, TGF beta and IL-6 did not correlate. On SLEDAI correlation, SLEDAI correlated well with both circulating immune complexes and the dsDNA levels, and there was also significant correlation with active sediments, low C3, low C4, and low hemoglobin. No other specific cytokines had direct correlation with SLEDAI scores. Conclusion, monocytes are depleted in active SLE, intermediate subset of monocyte percentage and their MFI are increased in active disease. Circulating immune complexes ELISA using C1q as solid phase for detecting disease activity may be used along with or instead of anti-dsDNA, and TNF alpha is elevated in active disease. The limitations were small numbers, stored PBMC was used for analysis, and limited number of antibodies used for as cocktail.
One question from the
I think steroids probably would have an impact on the monocytes, right? So you said that they were matched, but you had patients with active disease on the one side and inactive. So how was it possible to match?
So we had an exclusion criteria of steroid of 10 mg and above were not included in the study.
But 10 and the others maybe no steroid also.
Both of them, actually median dose was 0 only, ma'am. That's what I had shown in the table. But there were few on 2.5 and 5 mg, like that. but nobody more than that actually.
But do you think this is important enough to be used as a marker for how would you work further on this?
So there are a lot of individual studies of looking at this intermediate subset of monocytes in sepsis, in CLD, and in most of the inflammatory conditions. So, that way it is important. And another thing that has come out of this study is the circulating immune complexes. It is actually a ELISA kit which is commercially available. So in patients where you have doubt anti-dsDNA is not elevated, is it really active lupus, that CIC can be done. It had a better correlation between it and disease SLEDI rather than the even the anti-dsDNA.
It's revival of an old marker, I think. CIC used to be used long ago.
Yeah, but now it has improved, the sensitivity and specificity has improved with the better ELISAs. Thank you.
Thank you all the three presenters.
Stage, Dr. Takechi, Dr. Niharika Gill, and Dr. Molly Thaba. Dr. Takechi is the Vice President in the Medical University in Saitama. He is the Emeritus Professor in Kyoto University in Tokyo, Japan. Dr. Niharika Gill is the Head of the Department of Medicine in KG Sumaya Medical College, Mumbai, and Consultant Rheumatology in Lilavati Hospital, Mumbai. Dr. Molly Thaba is Professor in JIPMER, Puducherry. I would now hand over the mic to the chairperson to start the proceedings of this session, which is a virtual talk.
Thank you very much for coming in this keynote lecture. I would like to introduce the speaker. He is Dr. Shiva Prasada Rachandri from California, USA. And the title of his talk is T-cell directed therapies in autoimmune diseases. Dr. Rachandri, please, up to the stage. Or is this a web-based?
Virtual talk.
Virtual talk, okay.
Yes.
So, could you show us his presentation?
Hello, my friends and colleagues. I am Shiva Rachandri from University of California, Davis, and you can see our School of Medicine and the beautiful blue sky. And you can also see my wonderful members of my research team. I'm thankful to the Indian Rheumatology Association for inviting me to this annual conference. I consider this as an honor and a privilege. I convey my thanks and regards to Dr. Ashish Badika and Dr. Debashish Danda. Title of my talk is T-cell targeted therapies in autoimmune diseases and update. There's no conflict of interest in this talk. Autoimmunity is an immune response directed against an antigen within the body of the host. The definition does not distinguish whether the response is innate or acquired, and if acquired, whether it is induced by a foreign or an existing in vivo antigen. These are heterogeneous group of inflammatory, generally chronic disorders of an unknown cause. Autoimmune diseases affects multiple tissues and organ system. That's why these diseases are clinically challenging, associated with T lymphocyte activation and or autoantibodies produced by the dysregulated immune system. in autoimmune diseases, immune complexes together with the inflammatory cytokines cause the resulting tissue damage. This is a clinical talk to discuss T-cell targeted therapies for autoimmune diseases with a focus on rheumatologic diseases, mechanisms of actions, indications, and certain adverse effects. Generation of effector memory T cells and cell trafficking. As you know, the effector memory T cells are generated in the primary lymphoid organs, such as in lymph nodes. The antigen presenting cells presents the antigen to the naive T cells, and that activates and generates the memory T cells, memory in respect to the antigen. These memory T cells has to cross the endothelial cell barrier and then home in to the target organ and tissue, such as in skin in psoriasis, in gut in inflammatory bowel disease, in joints in inflammatory arthritis like psoriatic arthritis and rheumatoid arthritis, and in spine in spondyloarthritis. To cross the endothelial cell barrier, there is interaction between the endothelial cells and the T cells with several molecules such as ICAM and VCAM with CD11A, which causes addition of the T cells to the endothelial cells, and then under the influence of chemotactic agents such as chemokine, these cells migrate to the interstitium where the memory T cells get exposed to the antigen presented by the antigen presenting cell. As you see here, there are two key signals for T cell activation, one through the TCR and the MAC, and another through the co-stimulation molecule, such as CD28 on the T cells and CD86-80 on the activated antigen presenting cells. This results activation of the T cells and generation of array of cytokines, and these cytokines induces inflammation. Cause of inflammation and autoimmunity in autoimmune diseases is not clearly known, but there are two predisposing factors. One is genetic and another is environmental. Genes such as HLA-B27, HLA-C, IL-23R, IL-12B can make susceptible for spondyloarthritis, HLA-DR for rheumatoid arthritis, HLA-DRB1 for lupus, and HLA-DRB115 for multiple sclerosis. Environmental factors are very important, such as strep infection inducing gut psoriasis. Toxins such as drugs, hydralazine can cause flare of lupus, anti-malarials can cause flare of psoriasis and psoriatic arthritis. Biomechanical factors can be also important in inducing and localizing an autoinflammatory or an autoimmune induced inflammation, such as we see at the sites of enthesitis in spondyloarthritis. So there is a disease spectrum. Before the environmental factor, before the exposure to the environmental factor, and following that, there will be mild disease, and that may progress to severe disease. The state of the disease can be different at different time point. Can we quantify inflammation, determine state of inflammation in different time points, and apply this in management of autoimmune diseases? Obviously, as you see in this figure, in a collagen-induced arthritis model, the mouse was given chicken collagen, and that induced arthritis. You can see with time the paws are getting swollen, and with time mice were sacrificed, and we can see with time the pannus formation, and which is progressing with time, and following treatment on day 56, there was improvement. But these are semi-quantitative, and in human, it is difficult to do, biopsy. So we raised the question, actually, Dr. Smriti Reshwadar in our lab raised the question, can we quantify inflammation by molecular imaging? So by using the PET imaging in the CIM mouse model, we tried to do in vivo quantification of joint inflammation using PET imaging and CT in murine autoimmune arthritis. And you can see on the left panel that with the progress of the swelling of the paw and digits, the PET signal on the left side also increased. And in the last panel with treatment, the paw swelling improved, pannus improved, and also the PET signals reduced significantly. In two, we are getting the quantitative figures here. You can see with the time, the clinical score, the histological score, and the PET imaging course, that is SUV max, increased with time, and it correlated with SUV max. Currently, we are extending this study to human, and as you can see on the left side with PET imaging, how beautifully the synovial inflammation and as well inflammation of the flexor and extensor tendon, along with inflammation of the matrix in the fingers can be seen. So a tool for diagnosis and quantifying inflammatory burden of inflammatory arthritis such as psoriatic arthritis and rheumatoid arthritis is on the way. Coming back to cell trafficking in autoimmunity. So the current paradigm is shown here, addition of the specific pathologic T cells, migration and activation of those T cells, and generation of cytokines, and that will result proliferation, inflammation, and tissue destruction. So, it looks like that it was the other day, in late 90s, we raised this question, does this paradigm happen in human autoimmune disease? If so, can we block these processes? So we did few proof of concept experiments. Here, we took the help of Kebner phenomenon. We injured the skin and induced psoriasis, and then we did serial biopsy. First week, second week, third week, fourth week, and in the chronic, from the chronic plaque. And then we stained them with just, CD3 antibody to identify the T cells. And as you can see, with the Kebner, as there was appearance of psoriasis, with time, in the first week, you can see there is just perivascular few T lymphocytes. In the second week, these T lymphocytes are migrating towards the epidermis. In the third week, you see the T lymphocytes hits the keratinocytes, and there is a proliferation. And with time, there is more proliferation. And then we did another proof of experiments. So, if these T cells are and if we block these T cells, will you be able to improve psoriasis? So here we use a xenograft model, SCID mouse model, where we transplanted human psoriasis on the SCID mouse. In the figure A, you can see the unique picture of a psoriasis plaque proliferation of the keratinocyte, reticular formation, and then with the immunohistochemistry, the brown cells are the CD3 T cells. Then we developed a antibody, Fc silent anti-CD28 antibody, which I have already told earlier, that is CD20 interaction with CD80-86 is critical for perpetuation of T cell activation. So with the aim to block T cell activation, we used this Fc silent anti-CD20 antibody and treated the mice with that. And in the figure B, you can see almost normalization of the keratinocytes, and these T3 infiltrates are gone. So with this experiments and many other elegant work, the first anti-T cell therapy we got is abatacept. Abatacept is a soluble fusion protein compromising CTLA4 and the Fc portion of Ig1. It blocks co-stimulation of T cells and B cell interaction. In anti-TNF resistant RA patients, there was 50% clinical improvement with abatacept. Abatacept is a soluble fusion protein compromising CTLA4 and the Fc portion of the immunoglobulin G1, IgG1. Abatacept is available for psoriatic arthritis with excellent efficacy on psoriasis, rheumatoid arthritis, and juvenile idiopathic arthritis. Abatacept can be administered by either weekly subcutaneous injection or by monthly IV infusion following loading doses, and now it is in trial for psoriasis, lupus, and graft versus host disease. So the another approach could be targeting the cytokines of the T cells. So this slide, demonstrates the T cell subpopulation. Now in rheumatologic diseases, the most success has come by blocking the activity of the Th17 cells and its signature cytokine IL-17. Whereas for allergic disease, targeting Th2 cytokines such as IL-4, IL-5, and IL-13 has given a very good clinical success. So coming back to IL-23, IL-23 is a growth factor for Th17 cells. It acts on its receptor and then activates the JAK kinase system that activates the transcription factor ROR gamma T, and that leads to secretion of quite a few cytokines, IL-17, IL-22, but more so IL-17. With the identification of the Th17 cells, we got interested in Th17 cells, about 15 years ago, and then we are the first to show that the synovial fluid of psoriatic arthritis is enriched with IL-17 producing T cells. On the left side, in this FACS analysis, you can see in the figure A that most of the IL-17 is coming from the CD4 positive T cells. And in the figure C, you can see the memory cells, CD45RO, the effector memory cells, is making most of the IL-17 and IL-17A. On the right side, also with the immunohistochemical staining in the figure A, in the psoriatic synovial tissue, and figure B and C, we demonstrated presence of IL-17 positive T cells. Obviously, then we had to dissect the regulatory role of IL-23, IL-17 cytokine axis in psoriasis and psoriatic arthritis. We, and along with others, we have demonstrated IL-23, which is a heteropeptide composed of P40 and P19. P19 is specific for IL-23 because IL-12 also shares P40. That acts on Th17 cells, and that makes IL-17A, IL-17F, and the IL-17A and F dimers, and it acts on the IL-17 receptor. Both IL-17F, A and AF dimers acts on the same receptor. And then what it does, we demonstrated in respect to psoriatic arthritis that it helps in psoriasis plaque formation by inducing IL-8 and causes epidermatopism of T cells. It induces proliferation of the synovial cells, FLS, and causes inductions of IL-8 and MMP3. Others have shown its effect on endothelial cells, and obviously IL-17 activates the osteoclast through interaction of rank and rank ligand. Improvement of psoriasis following blockade of either IL-17 receptor A or its ligand IL-17A with secukinumab and ixekizumab confirms that IL-17 signaling plays a critical role in this immune-mediated disease. Now we have 3 IL-17 preparations. Brodalumab is an IL-17 receptor, a monoclonal antibody. Ixekizumab is humanized anti-IL-17A monoclonal antibody, and secukinumab, a fully humanized anti-IL-17A monoclonal antibody. However, IL-17 and its receptor monoclonal antibodies are in use for almost 10 years in psoriasis, psoriatic arthritis, and ankylosing spondylitis. So instead of speaking on IL-17, anti-IL-17, I will speak a little bit on IL-23, anti-IL-23, which is a relatively new medications for us. IL-23, a key regulatory cytokine in multiple autoimmune diseases, including in psoriatic disease. As you can see in the picture on the left side, IL-23 acts on gamma delta cells, Th17 cells, NKT cells, and ILC3 cells, and it induces an array of cytokines, IL-17, IL-22, GM-CSF, TNF-alpha, and it has a regulatory role in psoriasis and many other conditions like psoriatic arthritis, multiple sclerosis, Crohn's disease, ulcerative colitis. Its role on ankylosing spondylitis is not clear now. So as you know that I like proof of concept experiments, here on the right side you see that we have a very elegant model where we can induce psoriasis and psoriatic arthritis by IL-23 genes, IL-23 minicircle, the middle picture. Here you see compared to the control in the middle picture, in the mouse here, there is severe psoriasis, and when we treated with IL-23 antibody, there is significant improvement. This is to show the efficacy and safety of an anti-IL-23 monoclonal antibody in patients with active psoriatic arthritis over 24 weeks. As you can see in the bar diagram, compared to the placebo, PASI 75 response was almost 80% in treated patients with guselkumab. Similarly, ACR20 response was around 60% in the treated patient compared to around 20% in the placebo. Similarly, our group has shown the efficacy and safety of trilacizumab in patients with active psoriatic arthritis. And here you can see in this figure, the efficacy at the week 24, ACR20 response was around 80%. And then you see it could be maintained for 52 weeks. So now with time, we have several inhibitors of IL-23, which are ustekinumab, guselkumab, trilacizumab, and risankizumab. Ustekinumab is a human monoclonal antibody that targets IL-2 and IL-23, as shown in the figure on the right side. Guselkumab, a human IgG1 lambda monoclonal antibody that binds to the P19 subunit of IL-23. Trilra, similar to guselkumab, but a little different, a human immunoglobulin IgG1 kappa monoclonal antibody that binds to the P19 subunit of IL-23, and risankizumab, a humanized monoclonal antibody directed against the P19 subunit of IL-23. So guselkumab, trilacizumab, and risankizumab are specifically targeted against the IL-19 subunit of IL-23. There is some advancements with anti-IL-23 monoclonal antibodies therapies. Compared to IL-17 MABs, anti-IL-23 monoclonal antibodies can be used in patients with inflammatory bowel disease. Risk of candidiasis is less. Efficacy in psoriasis is better. The PASI 75 response is almost 90% compared to around 80% with IL-17 MABs. Longer duration of therapies, so less frequent administration is required. So 4 injections of guselkumab in a year will treat psoriasis and psoriatic arthritis. Similar to other biologics with anti-IL-23, immunosuppression is expected. While limited data exists overall on the safety and efficacy of IL-23 inhibitors, similar caution needs to be taken in the initiation of these drugs as we do with TNF-alpha inhibitors. So with time, we have noticed that anti-TNF and other biologics works effectively in only 50 to 60% of patients. As you have seen, the ACR20 response is around 60%, and biologics generally need to be changed on average in 3 to 4 years. This clearly suggests that other mechanistic pathways or a broader approach to counter multiple target molecules by small molecules could be effective and less expensive and thus widely available. So with time, we are seeing primary or secondary failures. So what's next? Can we block the preceding or the downstream events? So, we did a translational work to address this issue. What we find, you can see in these pie charts, that the effector memory cells, the TEM cells, both in rheumatoid arthritis and psoriatic arthritis are polyfunctional. Though in psoriatic arthritis, we are seeing these are skewed towards Th17 cells. You can see compared to RA on the left side, on the right side in the PSA, about 14% of the cells are making IL-17, whereas in rheumatoid arthritis only 5%. And probable explanation is that IL-23 receptor, you see, in the effector memory T cells at synovium, the pathological T cells has much higher IL-23 receptor. So probably that's the reason this is skewed towards the Th17 cells. But you see both RA and PSA, PSA is not only making Th17 cytokines and RA is not only making Th1 cytokines. Both are making IL-17, IL-22, TNF-alpha and gamma interferon. And the kinetics and dynamics of these cytokines could be different at different time points. So at some point, maybe there is overexpression of IL-17 and the patients are responding to IL-17, whereas at some point, maybe the TNF-alpha is more and they're resistant to IL-17 and they're responding to TNF-alpha. So then if we block two cytokines, will it be more effective? So that brings the concept of bispecific antibody, simultaneously blocking two cytokines with one monoclonal antibody. In the upper picture, you can see ABT122 is a dual variable domain antibody targeting TNF and IL-17A in phase 2 trial for psoriatic and rheumatoid arthritis. It is discovered by using a dual variable immunoglobulin technology. Then bimekizumab, already approved in Europe. It is a monoclonal antibody directed against both IL-17A and IL-17F. And bimekizumab has demonstrated higher efficacy of skin and joints in psoriatic disease. The ACR, the initial results suggest the ACR20 response is almost 80% with bimekizumab. Then finally, it brings up to this concept: how do we block multiple cytokines? JAK-STAT kinase pathway in the inflammatory proliferative cascades of autoimmune rheumatologic diseases, a novel therapeutic target. In this figure, it demonstrates that TYK2 and JAKs are recruited by multiple cytokines. This substantiates that JAK-STAT kinase cascades are expected to have a role in the pathogenesis of psoriasis, psoriatic arthritis, and ankylosing spondylitis because of involvement of IL-2, interferon gamma, IL-12, and IL-23. And as well in other immunologic diseases such as RA and lupus because of its regulatory role on IL-2, interferon gamma, and IL-6. So this brings to us targeting the signaling proteins for treatment of diseases. In this table on the left side, you can see the signaling protein targets, which are phosphodiesterase 4 inhibitor, and the drug is mentioned here, apremilast and crisaborole. JAK inhibitors, we have multiple JAK inhibitors: tofacitinib, baricitinib, upadacitinib, filgotinib, ruxolitinib, and I will show you more in the next table. You have these drugs which are doing very good for psoriasis and as well for psoriatic arthritis. And then the transcription factor, ROR gamma T, that can be targeted also with certain developing drugs. There are currently several JAK inhibitors in development of inflammatory indications. For inflammatory indications, here you can see the compound 1, 5, 6, and 9, which is tofacitinib, ruxolitinib, baricitinib, and upadacitinib, has been already approved for treatment of various autoimmune diseases, and others are in trials. So this is the list. This is the list is showing the first generation and next generation of JAK inhibitors. And the first generation JAK inhibitors inhibits multiple JAK kinase, as shown in this table, whereas the second generation JAK inhibitors have selective inhibitory activity for a specific JAK. In principle, this next generation JAK inhibitor might be used to treat selected inflammatory disorders with lower dose and less adverse effects. So this is the snapshot on JAK inhibitors. Tofacitinib approved in 2012, baricitinib in 2018, upadacitinib in 2019, and ruxolitinib cream approved in 2021. And this is interesting, you know, in addition to a rheumatologic disease, potential indication of JAK inhibitors in autoimmune disease of skin, and you can see these are very common diseases, and has definitely therapeutic efficacy on these conditions. So now tofacitinib has been approved by regulatory agency for the treatment of RA, PSA, ankylosing spondylitis, ulcerative colitis, psoriasis, and COVID. Baricitinib for RA and alopecia areata, and COVID. Upada for RA, PSA, AS, ulcerative colitis, and atopic dermatitis. Other JAK inhibitors are also promising. There is some use and some role of JAK inhibitors in COVID, cytokine syndrome. And as I mentioned, trials are going on various diseases, ILD, lupus, vitiligo, and others. So some key points on the JAK inhibitors: small organic molecules targeted against the signaling proteins such as apremilast JAK inhibitors, or anti-fibrotic molecules for ILD, nintedanib, a tyrosine kinase inhibitor, bring a new area beyond the anti-cytokine maps for the treatment of autoimmune and inflammatory diseases. JAK inhibitors are effective treatment for atopic dermatitis, psoriatic diseases, and various other diseases, as I have mentioned, and many other diseases are on trial now. Discussion of safety and adverse effect of JAK inhibitors in details is out of the scope for this talk. Overall, this safety is good and does not vary among different inhibitors. Risks of immunosuppression, increased risk of infection can be of concern, similar to other numerically high rates of deep vein thrombosis and pulmonary embolisms were seen in some studies in JAK inhibitors treated patients under the placebo. Second generation JAK inhibitors are more selective than currently approved drugs and are being studied with expectation to have better therapeutic efficacy and better side effect profile. And here I've given some good references. This is a developing field. This is causing a paradigm change in treatment of autoimmune inflammatory diseases. Some of our work is there, and I have put other important publications in this area. So this is the final slide. We like dreams and to turn dreams to reality. The figure on the right side with stars and balloon I drew with my postdoctoral fellow in 2020, with the idea that sky is the limit and we should explore and target hundreds of molecules for treatment of autoimmune diseases. The table on the right side is the real world now, showing array of successful therapies by targeting TNF, IL-6, IL-17, IL-12, IL-23, B cell, T cells by abatacept, and other signaling molecules such as apremilast and JAK inhibitor. I am sure many more are on the way. Thank you very much for listening to me, and If possible, I shall be happy to take your questions. Thank you very much.
Thank you, Dr. Rai Chaudhary, for a wonderful talk. And now the session is open to the floor. He can take some few questions.
From University of California, Davis, and you can see our School of Medicine and the beautiful.
I am Suvrat from Delhi. My question is, why is it that IL-17 blockers can cause possible exacerbation of inflammatory bowel disease?
Can you repeat the question, Suvrat?
Okay. So I am repeating my question. So I am Suvrat from Delhi. My question is, why is it that IL-17 blockers can cause a potential exacerbation of inflammatory bowel disease?
I think the screen is frozen or something. It looks like it's frozen. Yes, Suvrat, once again.
Okay. Okay. I think it is mute still.
Now it's moving.
শুনতে পাচ্ছ না?
Sir, am I audible?
তখন কোশ্চেনটা কমিউনিকেট
Looks like this isn't working, so maybe we close the session.
There's always there's some problem in this.
Yes.
If there's a problem, we can close this session because he can't get through us.
Yes.
Okay, thank you very much for your participation. The web connection is not so good, so I would like to close. We would like to close the session. Thank you very much for your kind attention and kind participation.
Okay. Thank you, organizers and the audience, for the patient listening. Thank you.